joining us today. It's my distinct pleasure to introduce Pierre Saintigny, who is Professor of Medicine at Université Claude Bernard Lyon and a medical oncologist at the Léon Bérard Cancer Center. He's leading the translational research team called Integrated Analysis of Dynamics of Cancer. He also co-directs the Department Tumor Escape Resistance and Immunity at the Cancer Research Center of Lyon. He's focusing most of his research in the head and neck disease from pre-neoplasia all the way to established squamous cell carcinoma, before and under selective pressure of systemic therapy. His scientific objective is to understand the longitudinal dynamics of head and neck squamous cell carcinoma before and under selective pressure, as well as to develop clinically relevant preventive and treatment strategies at these specific time points throughout the natural history of the disease. So without further ado, I'll turn it over to Dr. Pierre Saintigny.
Yes, thank you very much for your kind introduction. So today I will discuss with you, the experience we have on HTG on a very important topic. And the title of the presentation is Immunologically Hot Phenotype is associated with response to PD-1 inhibitors and is reliably determined in diagnostic biopsies. So this is my disclosure slides. Some of the results that I will present you are based on a research collaboration with HTG, where HTG actually provided reagent support. So before I actually start presenting you the couple of papers we've published on this subject using the technology HTG, I have a question. It would be interesting for me, to know exactly who are connected, your expertise. And so the question here is really to define who you are, clinician, molecular pathologist, scientist, bioinformatician, biomarker development researcher, translational medicine researcher, or, other or non-scientific role. So if you could, I guess, use the tools that BlueGene provides. So maybe I can go on and start the presentation. Okay, so I will do so. So the presentation outline is the following. There will be three parts. The first one is to present you our experience, so the number of samples and the type of quality of data we got using HTG technology, and we basically assembled all the data we have in a database, formal database that we call HIPSTER. So I will present you this in few slides. The main part of the talk will be on the second point, on the description of this immunologically hot phenotype defined through gene expression profiles produced by HTG and its association with clinical benefit from checkpoint inhibitors. And the third part will be a perspective, and of course we should have some room for questions, and that will be an interesting part as well. So the first part is to present you the HIPSTER database. So the HIPSTER is an acronym for HTG Transcriptomic Database Centre Léon Bérard. So Centre Léon Bérard is the hospital where I'm practicing medical oncology, and we've started working on this technology since 2017 with more than 1,700 processed samples for using HTG. So I can say that we have a reasonable experience on with this technology. And the data I will present you in the next 4 to 5 slides includes the analysis of 1,453 samples. And this is a work that was done by Valérie Attignon, who is responsible for the genomic core lab, Gebran Bouaoud, who is a surgeon and who participated to the study during his PhD program, and Lucas Michon, who is the bioinformatician of my group. So most of the samples for now have been analyzed using the oncology biomarker panel. So it's a panel that includes 2,600 genes. And as you can see here, there is a variety of tumor types that have been analyzed, with a majority of them, 400 or so, from the head and neck. Brian was just reminding you that my expertise is more on head and neck translational oncology, but there are other tumor types that we've included, including the lung, breast, and other tumor types. So it's a pretty diverse experience in terms of tumor types. More recently, we have profiled few samples using the precision immuno-oncology panel. So I think one of the key messages I would like to give you during the presentation is really the robustness of the technology. So, you know, when among these 1,400 samples, we had very few failures, and I think this is contrasting in our hands with what we get using FFP samples and standard RNA-seq approach. Here, the failure rate is 3.5%. So 51 samples, you know, were actually for which we were unable to get a profile of good quality that passed the quality control. There was no clear association between the number of slides that were macro-dissected, and as you can see, the vast majority, so this is in yellow, the vast majority of the samples were actually processed using one single slide. And there was clearly not really a clear association, maybe unless for the very, very tiny samples for which we had to microdissect a large number, a very large number of sections, 10 to 20, where, you know, maybe they were slightly more frequent, you know, in the samples rejected. So most of the samples passed the quality control, even though the vast majority of the samples were microdissected using only one single or two single sections. And these included surgically resected specimens as well as biopsies. So another important point is that we have the actual value measurements of the area that was microdissected, and this is thanks to the team of Valérie Attignon that kept this information, you know, since 2017, and basically, you know, there was no difference between the samples that passed or were rejected, you know, based on the area that was microdissected, meaning that the technology is pretty powerful, and even for very small samples. So let me now jump to the main part of the presentation, which is to present you a gene expression-based signature using HTG technology that is associated with clinical benefit to checkpoint inhibitors, PD-1, PDL-1 inhibitors in non-small cell lung cancer and head and neck cancer. So, of course, as I'm sure you very well know, for those who are scientists and researchers in the field, that this field of biomarkers in patients treated with immune therapy is a very active one. There has been a very high-profile paper published in Cell in 2021 by Charles Swanton group that looked at at doing a large-scale meta-analysis of more than 1,000 checkpoint inhibitor-treated cases who had whole exome and transcriptomic data, typically RNA-seq-based transcriptomic data. What they found is that the clonal tumor mutational burden, together with CXCL9 and CXCL13 expression, were the strongest predictors to checkpoint inhibitors. And one of the other observation is that using a multivariable predictor of checkpoint inhibitor response would outperform the value of tumor mutational burden alone. They had some additional observations regarding cyclin D1 amplification and 9q34 loss. Although the conclusion of this article is very interesting. One of the issue we have in the clinic is that most of the patients have small samples, and it's difficult to envision both to get enough material to produce tumor mutational burden together with gene expression profiles. And so I think we need also to think ahead, innovative approaches with robust technologies that would allow to get this kind of similar predictions without using too much tissue that we actually don't have in the routine care of patients. So this is the poll question 2 I have for you. Have you been involved in studies using FFPE samples to produce bulk gene expression profiles? So I put aside spatial transcriptomics, single cell RNA-seq profiling. Really here we are talking about bulk gene expression profiles. And if so, do you recall the technology that was used in the studies that you were involved in? So RNA sequencing, 3' tag-seq, microarray based, other known. So please take a few seconds to answer this poll question 2. And I will continue the presentation. So I listed here the many authors who participated to the study that was recently published in the European Journal of Cancer, back to back with another manuscript that will provide you with all the raw data, both gene expression profiles together with clinical data that will provide you, general clinical pathological information together with response, objective response, progression-free survival, and overall survival. So basically, we had a group of young folks who were motivated enough to, to gather the samples, to gather the clinical information. So these are Jean-Philippe Foy, Andy Karabajakian, Sandra Ortiz-Cuaran, and Maxime Boussajon. Of course, a team of pathologists who reviewed all the cases, who selected the area to microdissect. So Professor Sylvie Lantujoul, Carole Croze, and Isabelle Brocheriou. So these were pathologists involved in 3 different hospitals. And the clinicians, so both surgeons, Chloé Bertolus in Pitié-Salpêtrière in Paris, Jérôme Fayette, who is a medical oncologist in my institution, Centre Léon Bérard in Lyon, and Maurice Perrol, who is a pneumologist doing oncology mainly, so taking care of lung cancer patients. So we will describe 3 steps to define what we called the hot signature or hot score. Step 1 was to identify genes that were associated with immunologically active tumors and compute the hot score. So to identify those genes, we selected genes that were discriminating hot versus cold tumors using the TCGA head and neck squamous cell carcinoma dataset. We develop using the selected genes. There will be 27. We will compute the hot score using a gene expression-based scoring system that is called Gene Set Variation Analysis, GSVA. And we will validate the association between the hot score, PDL-1 expression, interferon gamma signature, and tumor infiltration, lymphocytes in the TCGA, lung squamous, lung adenocarcinoma, together with a cohort of ours at Centre Léon Bérard, a cohort of about 45 oral squamous cell carcinoma. Step 2 of the work is to evaluate the stability of the hot score. And this is for us something that is not often done very often, but we believe is very important when developing a signature that we aim to implement in the routine care. So to do this, we looked at the concordance of the hot score in diagnostic, pair endoscopic biopsy, paired with surgically resected specimens. And this is a cohort from Pitié-Salpêtrière in Paris. So I will tell you about this. We also looked at the concordance of the hot score on paired specimens from the initial diagnosis and recurrent head and neck squamous cell carcinoma. The last thing that we looked at in terms of concordance is to compare pre and post-treatment samples in patients treated with cetuximab, and this is a publicly available data set that we did not produce ourselves, that was done by others. The step 3 was to test the association of the hot score with clinical outcome to immunotherapy, and for this we looked at 2 different data sets, one from Centre Léon Bérard only, 102 patients treated with advanced recurrent head and neck squamous cell carcinoma. We called it CLB-IHN. And the other cohort is a 82 patient cohort treated with for advanced non-small cell lung cancer. We called NIVOBIO, that includes patients mainly from Centre Léon Bérard, but also from another cancer center in Dijon. And we also have 2 other, we looked at 2 other data sets of patients not treated and not receiving immune therapy, just to make sure that we didn't identify here a prognostic signature. So to start with, the step 1 was to define the signature. So we did a very simple thing. We used a supervised hierarchical clustering of 421 HPV negative head and neck squamous cell carcinoma from TCGA. So you can see here the heat map. And basically we excluded the HPV positive because we know they are highly infiltrated and we didn't want to take the risk to have an HPV related signature. We wanted really signature of hot tumors. So semi-supervised is because we limited the clustering to 354 genes that are included in the HTG oncology biomarker panel and that were tagged as immuno-oncology. So genes linked to response to in situ immune response, and that were tagged by HTG as being immuno-oncology. So a very pragmatic approach. The hot signature ended with 27 genes that were selected by comparing differently expressed genes among these 354 between cluster 1 and cluster 2. using a Wilcoxon test, selecting the genes that were changing the more with a fold change more than 4 and a corrected p-value less than 0.05. So this ended up with a 27 gene signature for which we compute in an individual sample a score using the GSVA. So you have here the list of the genes. You actually recognize, there is no secret here, the usual suspects. So for example, CD8A, that is specific of the T cytotoxic cells, CXCL13, CXCL9 that we know that are often associated, IDO1, interferon gamma that are very closely linked, and others that allow to identify those what we believe are immunologically active tumors. So when we developed this again in the TCGA head and neck squamous cell carcinoma dataset, HPV negative tumors. So we looked at the association, the statistical association between the signature and PDL-1 protein expression that is given in the TCGA. Actually, it's a TCPA by reverse protein phase arrays, RPPA. So you see that the hot tumors had actually a higher level of PDL-1 protein expression. The same for PDL-1 gene expression. And when we looked at a score that was previously published in the Lancet, I guess, the score of response to pembrolizumab, you can see that the hot score, the hot tumors had a much higher level of score response to pembrolizumab. Pembrolizumab being a PD-1 inhibitor. So then we looked at how this hot signature was associated in terms of immune infiltrate, and so we used a common approach that is now used that is called deconvolution of immune cell populations. So there are multiple algorithms. So we use the data provided by the TCGA. And as you can see, the hot score was predominantly associated with TCD8 infiltration with a correlation of 0.61. It was not associated with B cells. You know that TLS, tertiary lymphoid structures, are often associated also with response to immune therapy, but our signature is not associated with cells. And so the main population associated with the hot signature is TCD8. It's interesting also to note that there is no clear association of the hot signature with the mutation rate. You can see that the circles are purple, so corresponding to a correlation of points between 0.1 and minus 0.1. So interestingly, this hot score is not associated with the tumor mutational burden seemingly, at least in the TCGA. So let's see now how this validation of the association between hot score holds in a cohort of ours. So here we are moving to the CLB oral squamous cell carcinoma cohort that was published a while ago. So this is published in Annals of Oncology and the data is available publicly. So of course, a majority of males, even though it's pretty balanced. And the reason why it's pretty balanced is that this cohort was characterized by a significant percentage, about 40% of the patients being non-smokers, non-drinkers. And the main message of this paper in Annals of Oncology is that these two populations, smokers and non-smokers, differ by the immune microenvironments. Anyway, so you have the oral subsites, you have the staging. Most of those patients had no relapse, but some of them had some relapse, and we have the outcome. Although here we will not discuss, the outcome. We didn't look at this specifically. It was not the goal here of using the CLB OSCC cohort. The goal was really to look at whether the hot score status would be associated with an increased infiltration in CD8. So this is what you see. So we looked at the protein level of CD8, CD4, CD3, IDO1, and PDL-1. And as you can see, you know, the majority of the tumors that were hot were actually infiltrated by a higher number of CD8. We have the quantitative information that is very similar to what I'm showing here. Again, just to emphasize one point here is that in terms of PDL-1 expression, we see a very strong correlation between protein expression and gene expression. And we see that the level of PDL-1 is not strictly and very concordant with the hot status, which is interesting to us, meaning that maybe with the hot score, hot signature, we capture more precisely those tumors infiltrated by TCGA-HNSCC, and that may respond better to immune therapy. So this is the cohort in which we tested the association between the hot score and the outcome of patients treated for recurrent metastatic head and neck squamous cell carcinoma. So those patients were in majority male. So this is a real life cohort, not as the one that I just showed you. That was much more balanced between males and females. Most of them were current or former smokers, 85%. Alcohol consumers, unfortunately. You have the anatomical subsite of these patients. A majority were actually HPV negative, few were HPV positive, and we don't necessarily measure HPV in all patients. We do it only in patients with oropharyngeal disease that was not the majority of the patients. So those patients were ECOG performance status mainly 0 to 1. So patients with a good performance status. And most of those patients were treated before by immune therapy. In general, in the context, not with immune therapy. So the majority of them received already 56% previous lines of systemic therapy, but you can see that 44% of them actually didn't receive chemo before. So this is at the time where immune therapy was evaluated in second line mostly, but also in first line in the context of clinical trials. And most of the patients were included by Jérôme Fayette. So you have the complete response, 5%, 5 patients, partial response, 6%, stable disease, 7%, and progressive disease, 60%. So this is the Kaplan-Meier curve looking at overall survival and progression-free survival. And you can see that patients which tumors were hot were actually doing better, both for overall survival and progression-free survival. This is a multivariate analysis considering the age, the performance status, and previous lines of therapy. I want to emphasize this analysis because in many of the reports of gene expression signatures or whatever biomarker associated with immune therapy, this kind of multivariate analysis is almost never presented, although we know performance status is an important marker and age is a very important prognostic factor as well. So as you can see, the hazard ratio associated with the hot score, hot status was 0.48 with an hazard ratio of 0.31 to 0.74. And so this is for overall survival, and for progression-free survival, the hazard ratio for the hot status was 0.52 for a confidence interval being between 0.34 and 0.80. This was requested, these graphs were requested by the reviewers of the European Journal of Cancer. They wanted to see the score, the actual score, not only the status, in patients having progressive disease, stable disease, partial response, and complete response. And also having, using the cutoff, number of patients alive and being alive less than 6 months versus more than 6 months. An interesting observation is that the cold tumors really have a clear enrichment in those patients, doing very poorly. And maybe that's also an interesting marker, not only to identify those patients most likely to benefit from immune therapy, but maybe patients that we should exclude. So this is something that needs to be studied in more detail. So let's go now to the cohort of patients, because as you understood, the signature HOT was developed in patients in tumors, in head and neck squamous cell carcinoma tumors. So we wanted to see whether this was the association with the benefit to immune checkpoint inhibitors was also observed in patients from different tumor types. And so we looked at non-small cell lung cancer. Again, this is a cohort at the time where immune therapy was used as monotherapy in second line or third line therapy. And so this is, the characteristics of this cohort of 82 patients from Centre Léon Bérard and also from Dijon, Professor François Guéringhelli. So interestingly, the association was also pretty strong. Where the HOT phenotype was status was associated with an improved overall survival and progression-free survival, both statistically significant. And we also, had even though it was not as strong, you will note that the confidence interval goes for overall survival from 0.36 to 0.99, and for PFS, from 0.34 to 0.93. But overall, the hazard ratio is pretty close to what was observed in head and neck cancer, with an hazard ratio, in between 0.5 and 0.6. And very similar results observed in terms of correlating the HOT score with response or with, survival less or more than 6 months. So very recently, so I will not go over the details, but we actually looked at publicly available data, and I don't know if you are aware of this cohort that is called IATLAS. So we actually did some cleanup, among the information that is available, and in our hands, we end up with a cohort of 592 patients that mostly include bladder, and to a lesser extent, melanoma and kidney, and to a lesser extent, stomach. And what we were happy to see is to see a strong statistical association again between the HOT score in the IATLAS cohort, a cohort that is made of tumors that were not included in the training cohorts, the TCGA head and neck squamous, and in the other cohorts that we use to look at the association with benefit to immune therapy. So to move to things that are very important in the routine care of patients, is there any impact of the run that in which the samples were processed? So here, this is from the cohort of Pitié-Salpêtrière that had both tumor biopsies collected through endoscopy at the time of diagnosis of oral cancer, and SRS samples, which mean surgically resected specimens. And as you can see, there was no clear considering gene expression profiles as a whole, including all the genes, there was no really impact of the run A, B, and C, so 3 different runs to process those samples. No impact on gene expression profiles. The other thing is that we wanted to know whether the biopsy, the nature of the sample, either a biopsy or a surgically resected specimen, would also impact, and we didn't see any. The stability is also important, especially in the context of the development of neoadjuvant therapies, in which more and more combinations associating checkpoint inhibitors and chemotherapy are being developed and seem to provide interesting results in this pre-surgical setting. And so we wanted to see, whether there was a stability. So the panel on the left shows you the stability, the impressive stability in the biopsy versus surgically resected specimens with no treatment between the biopsy and the surgery. And except for few cases, especially one that really changes, in terms of status, hot and cold, there was a very interesting stability that encourages us to use this as a way maybe to stratify patients in these neoadjuvant clinical trials. Another observation is that cetuximab may actually impact, so we have less stability, in pre versus post cetuximab, given to patients. And also, and this was published previously, I will present you this in the next few slides to finish my presentation, but we had significant differences between the hot core and the hot status, in the sample used for diagnosis as compared to the sample used at the time of recurrence. So these are paired samples from the same patient, and I think that is very important in terms of advocating rebiopsies, even if the recurrence is clinically obvious, but to especially when thinking of the treatment for patients when they have recurrence. So this is coming from, another paper that was published in Oral Oncology in 21, where we looked at, the longitudinal assessment of PDL-1 expression by immunohistochemistry using the standard approach, and gene expression profiles, so in head and neck patients, cancer patients. So this is from the group of Centre Léon Bérard. You can see here the list of the patients, and some of them had actually, all of them had recurrence, and the idea was to compare the biopsy in terms of PDL-1 protein expression by IHC and gene expression profiles, baseline and at the time of disease recurrence. 35 patients. So as you can see, when you looked at the CPS score, of PDL-1, you can see that, in 12 patients, the score was different. 12, of the 35 was different, at diagnosis and at relapse. And it could go in both ways, low versus high and high versus low. And so that's, I think, an important message advocating for rebiopsies. We looked at gene expression profiles that are surrogate of tertiary lymphoid structures and interferon gamma activation. And here again, about 30% of the samples were, saying different things between diagnosis and relapse. And so this is just a summary of those results, in which you can see that the TLS signature score was high at diagnosis in 16 patients, and it remained high in 7, but in other cases, it actually was considered to be low, based on the median of the signature. And even though you have less changes when patients have a low signature score for TLS at diagnosis, with few of them changing, there are still some changes possible, especially, this one that is changing. And this is for the interferon gamma signature. Bottom line, what you need to remember is that in our hands, based on this experience, this paper, about 30% of patients change somehow their status in terms of PDL-1, IHC, or gene expression profiles. And so to end the presentation, I will give you a few perspectives. So of course, what we would love to do also is to study the association, the correlation between some of the gene expression based classifications that have been proposed. So it's not really possible to do it using the OBP, Oncology Biomarker Panel, but we have now with HTG a whole transcriptome panel that includes, I guess, 19,000 to 20,000 genes transcripts. So you know that for head and neck, especially, there has been 4 subtypes proposed based on gene expression profiles that I think would be very important to consider when developing new approaches to treat patients. There has been, of course, those immune subtypes, that have been proposed, and head and neck squamous cell carcinoma end up in 2 main subtypes, the C1 that is associated with wound healing processes, and the interferon gamma dominant one that, is, so the head and neck squamous fit in these 2 categories mostly. And more recently, there has been, immune subtypes proposed, and I guess more refined way to describe the landscape of squamous cell carcinoma in general, and because this has been applied for cervix, esophagus, lung, and head and neck, and you can see the huge heterogeneity and the different characteristics that are being present when considering interpatient heterogeneity. So a huge heterogeneity, and I'm sure that we will need to include those things, to stratify patients in the future. And finally, this classification that takes into account not only the immune subpopulations, but also the fibroblasts, the cancer-associated fibroblasts that more and more, are the subject of studies showing that they impact how the immune cells shape the tumor, and how they interact with the response to immune therapy. And finally, of course, and this is work from the lab, using different approaches, single-cell RNA-seq, in tumors together with spatial transcriptomics, and of course the game here is to identify the different populations that are present, and then to project them spatially in using other approaches such as the Visium from 10x, and so these things are ongoing in the lab. Another way to apprehend the tumor ecosystem is to, at the single cell level, is to use this kind of approaches. This is a picture of multiplex immunofluorescence. So the hot score, of course, is an analysis done, on bulk tumor, very pragmatic approach for everyday, patient care. But in the future, clearly we will have to do more than just looking at bulk analysis. So this is the last slide, to thank you for your attention, to thank my team and all the people who participated to this work. And maybe going to the ending with this poll question 3, just to make sure that I was clear enough. What step must one take to develop a hot oral tumor score? Identify genes of interest and compute the hot score, evaluate the stability of the hot score, and measure the concordance. Test the association of the hot score with clinical outcome to immune therapy, all of the above. Okay, thank you very much, and I'm of course open to answer any question that you may have.
Thanks very much, Dr. Saintigny. Very elegant presentation, easy to understand, and some great data as well. So thanks very much. And an interesting time point, as you allude to, with that essentially the chemotherapy followed by immunotherapy, a very unique cohort, and some nice observations. We have a question from Dr. Kasem, and I'll attempt to get to the root of the matter. One question was in regards to the longitudinal change, which I think you did a nice job of describing, but maybe you can just reiterate, if the gene expression profile does not show sort of activity or a hot score, but then may later on develop that and be, let's say, suggest benefit from PD-1 inhibitor therapy. Any suggestions in terms of, how frequently you would look for that, or, how can we proactively apply that understanding?
Well, it is clear that the tumors are changing with time, and a tumor that has been treated 2 years later, and that is relapsing, we will may keep some common features with the one treated 2 years ago, but may also have some may have some differences also biologically. So this is what we wanted to test it in this study, and we actually observed, and I don't think there was other studies really studying at this using this approach. What we just observed that some patients remain the same, but some patients actually have different biological features, in the tumor that mean that I think this advocates clearly the need to even for the most simple one, which is PDL-1, to actually rebiopsy the patient and to test again the sample before making any choice. I think it's important.
Very good. And then a follow-on question to that was in regards to heterogeneity within the same patient. And so did you observe any tumors that had both a active and inactive signature? And if a clinician were to experience that, what recommendation might there be?
So heterogeneity, intra-tumor heterogeneity, you mean?
Exactly, yeah, or at least intra-patient.
So from do you see still my slides?
We can pull them up.
No, it's just because I want to go back to this figure here. Tell me if the people
we can see it now.
Okay, so here clearly in the left panel, it's what we see is against intratumor heterogeneity, because we compared paired tumor biopsies done at the time of the initial workup of the patients coming in with a new diagnosed oral cancer. And we compared this biopsy in terms of the hot score with the hot score on the downstream surgically resected oral cancer. So the whole tumor in a way. And so this is going against heterogeneity, at least for the hot signature, because we had only, let's say, 3 patients who changed their status from hot to cold. So it's a bit of a surprise, but this is how it is.
Great, very, very insightful. Thank you. We have another question from Dr. Brian Bird, and he's curious if we've used RNA measured in serial blood samples. And a follow-on question is, could CTLA-4 potentially turn a cold tumor hot, in your opinion?
So no, we didn't look at blood. So I know some colleagues are doing this. It is very possible that CTLA-4 puts a cold tumor into a hot. Unfortunately, in head and neck, the combo PD-1 or PDL-1 plus CTLA-4 inhibition was not very successful. So it's hard to answer this question. I think for now we don't have enough evidence, clinical experience, clinical trials of CTLA-4 inhibition, that would bring something additional to PD-1, PDL-1. But there are other immune checkpoints that are being studied in combination with PD-1, PDL-1.
Perfect. And again, we have time if anybody wants to enter a question in the chat box. And I'll just ask a question related to your commentary about the changes now in therapy. And given the current backdrop, perhaps for a shift to concomitant therapies, what do you see as the relevance and the, pull out your crystal ball, what do you see as the future looking at the application of hot and cold scores in that scenario?
So I think it depends on the disease. So although we are very happy to see that the hot score seems to be associated with an improved outcome in different tumor types, I think really here we have to think tumor type by tumor type. So in head and neck, there is clearly no good biomarker. And also the percentage of patients benefiting from PD-1, PDL-1 inhibition are actually not as high as we can see in lung, but even more in melanoma, for example. So I think we have to I think I would be tempted to identify biomarkers. Maybe the hot score is one of them. We saw that I showed you some graphs showing that the hot score would maybe be used as a way to exclude patients at some point rather than including them in immunotherapy. This has to be tested in multiple other cohorts before we can really give a definitive answer to these hypotheses. But in general, I would think that it would be very useful not only to have biomarkers of clinical benefit to immune therapy, but also to have biomarkers that would exclude patients that will actually not get any benefit. And so I think that's in terms of perspective would be interesting to study.
Wonderful. Well, thank you again, Dr. Saintigny. A really concise and informative, insightful presentation for which we are very grateful, as well as for spending your Friday evening with us here online.
Okay. Thank you very much to all of you for listening to this presentation. I hope it was useful to you. Of course, I'm happy to to exchange, to have discussions after the presentation, and this area, more than others, we need to collaborate all together.
Well, thanks again. Before we sign off, we do have one late breaking question here, and I think it's another interesting topic. But Dr. Bird asks, have you looked at fecal microbiome and its correlation to multiomics or the hot score?
No, we didn't. We didn't. I have absolutely no data to provide you, to study the association between any kind of microbiome data and the hot score.
Okay. Well, great question, and lots of very exciting areas for future research.
Exactly. Thank you.
Okay. Bye, everyone. Thanks so much.
Thank you. Thank you. Bye-bye.